Welcome everyone to this Edwards Life Sciences webinar in collaboration with CTSNet, Advances in Valve Tissue Technology and Why It Matters. Thank you for joining us. Please note this webinar is being recorded and will be available this Friday on ctsnet.org and CTSNet's YouTube channel. At this time, I'm pleased to introduce Dr. Joseph Bavaria, who will be moderating this webinar. Dr. Bavaria is the Vice Chief of the Division of Cardiovascular Surgery at the University of Pennsylvania, where he is also the Director of the Thoracic Aortic Surgery Program and founder co-director of the Penn Aorta Center. Of note, Dr. Bavaria was also the 52nd president of the STS. Welcome, Dr. Bavaria. I'll turn it over to you.
Well, thank you. Thank you very much. I would like, first of all, to thank Edwards for putting on this this webinar through CTSNet. And I'd like to introduce the two other speakers. Michael Borger from Leipzig, Germany, will be with us today, speaking on the EU guidelines and real-world impact for lifetime management decision-making in aortic valve surgery, as well as Dr. Thomas Beaver from the University of Florida, who's a professor-in-chief of cardiovascular surgery there, and also recently presented the 7-year COMMENCE trial data at the AATS. So we're very proud to have both of them here with us this morning. So without any further ado, I'd like to go ahead and ask Dr. Beaver to begin his presentation on the 7-year data.
Thank you very much, Joe. I'd like to just start out by just talking about RESILIA tissue in general. And there are over 80 countries around the world, and these products aren't available everywhere. But when we talk about structural valve deterioration, we're talking about the wear and tear on the valve, leaflet disruption, but importantly, leaflet calcification. And when you talk about designing heart valves, we talk about the material itself, which is the leaflet tissue, in this case, bovine pericardium, how the valve is constructed or the design of the valve. In some cases, some valves have wrapped the pericardium outside the struts, which has design implications and failure implications versus inside the struts. And then finally, how the tissue is processed itself. So the tissue fixation, the anti-calcification technology, and that's really what we're talking about this morning. So in terms of the Edwards tissue.
Tom, I'm sorry, you're gonna have to share your screen.
In terms of the tissue progression for Edwards, in the 1980s, really it was just about preserving the tissue with glutaraldehyde. And then in the later 80s, phospholipid extraction became important with the xenologic technology, as we learned that the glutaraldehyde or the tissue had to be washed of the phospholipids to prevent calcification. And then later, Thermofex was developed, which actually stabilized the glutaraldehyde, and that led to further advancements with the tissue. And then finally, what we're talking about today is the RESILIA tissue process itself. And with the RESILIA tissue, we're actually using two techniques to really cap the glutaraldehyde residual aldehydes, and then also glycerylation. So this tissue has been proven in animal models. This is actually a sheep model of accelerated calcification. On the left, you'll see the prior generation tissue, and on the right, the RESILIA tissue. And you can see graphically with this radiographic image, the calcification is less in this RESILIA tissue. So the way the RESILIA tissue works is during the glutaraldehyde preservation process, free aldehydes are created. These can oxidize and then bind to calcium, and then that can lead to calcification of the tissue. The way the RESILIA tissue works is it caps those free aldehydes. So by capping those free aldehydes, it prevents calcification. A second major component is the glycerylation of the tissue. And by doing that, it displaces the water in the tissue and allows the tissue to be stored with dry storage. And this is important because you don't have to store the tissue back in glutaraldehyde. Now, the RESILIA tissue story starts back in the early 2000s with extensive laboratory and benchtop work. And then I showed you the sheep model and the animal models. And then subsequently, there were two major clinical trials. The first was a feasibility trial out of Europe. And then the second was actually the 5-year COMMENCE trial with using RESILIA tissue in the aortic valve. This has led us to the present day where we're sharing you the COMMENCE 7-year follow-up. But there's several other ongoing studies looking at CT scan performance of the valve, looking at how the valve performs in younger patients, how it performs with other comorbidities, and importantly, the Momentous study, which will be looking at the mitral valve. So the RESILIA tissue has now been incorporated into all of the Edwards portfolio. So you'll see it on the Inspiris RESILIA aortic valve, the Connect valve conduit, the Mitris RESILIA valve, and also now on the transcatheter valves, including the SAPIEN 3 Ultra. I'm going to stop sharing here, and then I'd like to share with you the exciting data from the 7-year outcomes of the COMMENCE trial. So on behalf of all the COMMENCE investigators, the Edwards team, and all the study coordinators, it's really a privilege to share this data with you this morning. Disclosures here. So when we talk about valve prosthesis, it's and choice for valve for patients, it's really, we're looking at a variety of factors, but it's not limited to valve durability, the need for lifelong anticoagulation, patient's lifestyle. And especially as we look at younger patients, durability is a significant concern. I just shared with you how RESILIA tissue incorporates this novel integrity preservation technology, and it's been incorporated into all the Edwards product line. So there are two trials already sharing 5-year data. There was a European study out of 2 sites in Poland that showed the feasibility of the RESILIA tissue. And then the international COMMENCE trial, actually, Dr. Bavaria was first author, published in Annals of Thoracic Surgery last year. These studies involved hundreds of patients. They both involved the model 11,000A RESILIA valve. Importantly, both had an independent clinical events committee that adjudicated the safety endpoints. And they also had an independent core lab that followed patients for 5 years. The patients in both these studies showed stable hemodynamics out to 5 years from the core lab. So when we talk about younger patients, which we'll be talking about, hopefully have plenty of time to discussion today, really this durability becomes important. And today we're sharing with you now 7-year data from this trial. So again, to refresh your memory about the study design, all potential endpoints were adjudicated by an independent clinical events committee. This was based on the Aiken's criteria for structural valve deterioration, which was the predominant definitions at the time of the trial in consultation with the Food and Drug Administration of the United States. And then the effectiveness endpoints, again, importantly, we had an independent core lab for this trial, and a New York Heart Association functional class was noted as well. The inclusion and exclusion criteria were pretty standard. These were adult patients with aortic valve disease. Concomitant procedures were allowed, though 60% of the patients were isolated aortic valves. In terms of exclusion criteria, no emergency surgery, no endocarditis, multiple valve replacement was avoided, and prior redo surgeries were excluded for the trial. In terms of the original cohort, there were 689 patients that received the valve. You'll see the mean age was 66.9 with a follow-up of 5.3 years. On the circle on the right, you'll see the majority of the patients received a full sternotomy. The valve distribution is noted in the left lower quadrant. And you'll see that 78% of the patients had a 23 size valve or larger. On the right-hand side, you'll see the majority of the patients were male. The SDS was 2, and most patients were class 2 heart failure, and most patients were 66 to 79 years of age. Now, these patients were there were 694 enrolled patients, 689 I just showed you received the valve, 5 did not receive it either due to technical or anatomic complexities. They were followed up to 5 years, and at this point, the Food and Drug Administration of the United States asked that additional follow-up out to 10 years be performed at the top 3 enrolling centers. The sponsor, Edwards, then asked all centers if they would be interested in enrolling patients, and all patients were offered to continue enrollment. Now, 30 did not have their 7-year follow-up. There were 9 patients that exited prior to the 7-year visit, 7 due to death and 2 to explant. There were several patients that missed their 7-year window. This was in the time of COVID and logistics were of concern. And there are actually 4 patients that still have their 7-year visit outstanding. So of the reconsented patients, now there are 225, and you'll see the age was essentially the same at 65, but now the follow-up is 7.7 years mean follow-up. Again, most patients you'll note had a full sternotomy. And you'll note in the left lower quadrant, the valve size in the reconsented patient was slightly larger, just over 80% now, a size 23 or larger valve. Again, majority of the patients were male, STS score of 2, most class 2 heart failure, and again, most patients 66 to 79. The early endpoints were excellent. The mortality was low, it was 1.2%. The stroke rate was low at 1.6%. Minimal bleeding events. There was one perivalvular leak that did require reoperation at 6 days, and that was the only reoperation early on. Here's really the crux of the matter, what we're talking about this morning. This is the seven-year data, the safety endpoints through 7 years. On the left-hand side, you'll see the endpoints or variables for the various outcomes. And the second column are the number of patients at risk, and the third column are the events. And now we're looking at probability event-free survival or event-free at 7 years. So the mortality event-free at 7 years is 85%, or essentially survival would be 85% at 7 years. 94% freedom from stroke. Most of the bleeding events were related to anticoagulation for atrial fibrillation. There were 15 endocarditis events, and 7 of those did require reoperation. There was the early perivalvular leak, another one that resolved, and another one that required a perivalvular plug. Importantly, there are only 2 structural valve deteriorations in this cohort, so 99.3% freedom from structural valve deterioration. There are 12 reoperations, which I'll talk about in a little more detail here. The early perivalvular leak, 7 endocarditis events, most of these were staph or strep. There were 2 patients with structural valve deterioration that I'll talk about in a little more detail. And then there was 1 patient that had an enlarging aneurysm that did require reoperation. So in terms of the structural valve deterioration, the first was a 67-year-old female. She had atrial fibrillation, hyperlipidemia, hypertension. She had a 21 millimeter valve implanted. On the right-hand side in green, you'll see the follow-up at 1, 3, and 5 years. The next column is the New York Heart Association classification. The next column is the effective orifice area, then the mean gradient and ejection fraction. You'll see a slow increase in gradient over the ensuing 5 years. And in fact, at 5 years on a TE, she was known to have a mobile leaflet. So this 21 millimeter valve at the behest of the structural heart team had a 26 millimeter transcatheter valve placed, which is really a nice result for that patient. The second patient was a 71-year-old female. She had peripheral vascular disease, chronic kidney disease, COPD, and obesity. She had received a 25 millimeter valve. Again, on the right in green is the follow-up, and you'll see in the ensuing columns the heart failure classification area and gradient. You'll note she had through 6 years normal valve function, but just at the 6-year mark, she had a drop in her effective orifice area. She did have heart failure symptoms and received a mechanical valve, as the team at that center felt that due to her chronic kidney disease and peripheral vascular disease, she was at risk for tissue degeneration again. In terms of the hemodynamic performance of the valve, on the top in the green is the millimeters of mercury gradient. Just below that is the number of patients at risk. On the vertical axis, on the y-axis is the millimeters of mercury. And then on the horizontal axis, out to 7 years, is the years of follow-up. Below, you'll see the individual colors associated with each individual valve size. The effective orifice area is presented in a similar manner, again in green across the top with the number of patients at risk. And then on the vertical axis would be an orifice area, and on the horizontal axis, out to 7-year follow-up, again associated with individual valve sizes with each of the colors. In terms of perivalvular leak, essentially 99% trivial or none at 7 years, the percentage of patients on the vertical axis, and the years of follow-up with patients at risk below. And the valve performance itself was excellent. Again, 97% trivial, none, just a few patients with mild transvalvular regurgitation at 7 years. So now with excellent outcomes through 7 years, the COMMENCE trial demonstrates really encouraging results with RESILIA tissue. These low rates of structural valve deterioration, stable gradients, and freedom from regurgitation over the period all support valve durability with a 99.3% freedom from structural valve deterioration through 7 years. And ongoing follow-up, we'll continue to follow this cohort through 10 years, and we'll really get an excellent determination of long-term safety and effectiveness of this new RESILIA tissue. So I'll stop there, Joe, and let you and Michael continue on. Thank you.
Thank you very much, Tom. What a great presentation and great data. First of all, I'd like to say to everybody out there, try to use the Q&A instead of the chat if you can to ask questions, and we'll monitor those questions. Sorry about that. I should have said that earlier. So I will give the next presentation, and I will go to share screen. Did you stop sharing?
I believe I'm sharing now then, Joe. I think you're good.
Okay. Okay, can everybody see my screen?
Yes.
Okay, great. Okay, so I'm going to be going over the U.S. guidelines overview and a 5-year COMMENCE aortic trial BAV data in the context of lifetime management, and really focus a little bit on younger patients. So these are my disclosures. So, you know, the older valve guidelines of both US and Europe basically had this kind of cutoff at 60. There was a little bit of both valves in the middle, and then above 65 or 70. So let's take a look where we are at this point, especially regarding the nuances and real practices that we all see every day. So these are the new guidelines. These are the new American guidelines. And what you can see here is that there's a couple of interesting things that have happened with the new guidelines. There's lots of additional 2A recommendations, looking at BMP, for example, and velocities, as well as low gradient AS and AVR is recommended, as well as low flow, low gradient severe AS. It's kind of interesting. These little nuances are pretty important. And the big picture is that there are more indications for AVR representing a deeper understanding of the disease process than in the previous sets of guidelines. You'd be surprised how many people will end up getting AVRs extra compared to before, looking at these 2A and even that 1-2B indication as noted in these guidelines. So my recommendation to everybody is get with the guidelines, so to speak, so you can understand them a little bit better, especially in your clinics. These details include BMP, EF less than 50%, increasing velocity, and even less than 60% EF if it's progressive. And this is the recovery trial, which informed the guidelines in a big way. This was presented at the American Heart Association in the New England Journal of Medicine right before the guidelines were written. And what you can see here, this trial shows that there's very severe AS needs AVR, and needs AVR pretty quickly, even if asymptomatic. This was, will actually get into the guidelines and has been in the guidelines. So this also shows how excellent SAVR is. And as you can see, these were really low risk patients. STS score was about 1. There was 0 30-day AVR death and 0 CV deaths out to 3 years, which is actually, you can see that red line there, out to 3 years, there was 0 CV deaths. So what this really shows is that from a surgical standpoint, it's a prospective randomized trial. AVR and severe AS, velocity greater than 4.5 is really important and really very, very satisfactory. So what about the guidelines and the young? Well, for patients 50 to 65 years old, there's who require a contraindication to anticoagulation is reasonable, as well as any patient greater than age 65 require AVR. It is reasonable to choose a tissue valve, which is not really that much different. But the bottom line in the big picture is that these new guidelines lower the 2014-2017 guidelines for tissue valve consideration to less than 50 from 60. Okay, so basically they changed it for a decade. This is really important. So this is more aggressive than the actual European guidelines, which will be presented in a bit by Michael Borger. And you can see also that, that what this does, this provision here, basically makes the tissue versus mechanical somewhat academic because it allows anything. This is for patients in any age group who would rather not take Coumadin, basically have the right or have it's reasonable to choose a tissue valve. So this puts out an emphasis on the risk of anticoagulation versus reoperation. Now, the European guidelines also show the same situation as the American guidelines regarding this particular concept, which is pretty new actually. So what is the data behind this? Do we have some newer data behind this guideline tissue permissiveness in younger patients? Well, first of all, we can look at this outstanding New England Journal study by Andrew Goldstone looking at mechanical or biological prostheses. And what you can see here is really interesting. This excellent study showed relatively equal outcomes in ages 55 to 65, as you can see there in the panel B, and even fairly close in the 45 to 54-year-old group, even though it was statistically significant, but you can see the lines are pretty close. And this is using much older technology, valve technology, than the Inspiris valve or RESILIA tissue. And if you look at the hazard ratio, it really goes below unity at 62 for tissue valves, but it isn't statistically significant until about 52 to 53, as you can see in those red lines there. Now, additionally, you can look at this study out of JAMA showing the long-term survival in ages 50 to 70, really kind of looking at the old guidelines and what they mean for bioprosthetic versus mechanical valves. And this was an interesting study looking at a propensity match analysis of 1,000 patients on each side. And you can see there's basically absolutely no difference. This was equal survival in patients between 50 and 69 years old between mechanical and tissue valves. And this is actually obviously an older type of valve platform. And this is an interesting study looking really at Ross patients, okay? But what happened when you see this is you can look at the Ross data, and that's really nice for the super young, but also that tissue is as good or better than mechanical in these younger patients. So this was actually, even though they weren't really studying this, this was actually the first time that this has ever been shown in these younger patients. And this, again, propensity analyzed at about almost 500 patients in each of the three groups. So now going beyond the consensus, looking at BAV, bicuspid aortic valve in particular, and the young, and the COMMENCE trial BAV results. Now, the first thing is that everybody has to understand, this is a very important slide, looking at the congenital BAV. This is all Sievers 1 or Sievers 0 BAVs. And what you see here is that by this study, and this has been repeated, is that BAV-AS, this is important, BAV-AS for the same amount of gradient has 2.5 times the calcium load as three-cuspid aortic valve aortic stenosis. So this is a really important point regarding kind of how you approach a BAV patient from the standpoint of tissue valve, mechanical valve, or TAVI. So this is data that I'm going to go over on bicuspid aortic valve COMMENCE trial. 5-year data was presented last year at the ATS, exactly 1 year ago. And when you look at the BAV versus TAV subset, as you can see here, the mean age is 59 compared to the TAV, which was 70, which is very, very important. You can also look at that it's a pretty low risk patient population. BAV is 1.2 STS score. Interestingly, the TAV STS score is 2.3, which is actually higher than the low risk trials, low risk TAVI trials. So the original study, COMMENCE study, had 689 patients, and after you look at all the bicuspids, which was really an incredible amount of bicuspids, 214 BAV patients, of which we had really young patients, less than 65, 133, and then between 66 and 75, we had 69. So we're looking at both sets of patients compared to the TAV group on the right, with 458 tricuspid patients. And interestingly, we didn't actually think this was going to be the case, but as you can see, the stenosis, insufficiency, and mixed were actually exactly the same. I actually thought beforehand that there might be more AI patients, but there wasn't. What you can see here, and this is typical, and basically tells us something we probably already knew but never really studied, is that the BAV patients have larger valves. And you can see here that the BAV valves were a little over 1 millimeter bigger on average over the 200 and some odd patients, as you can see, trending more towards 25s and 27s. Now, this is the safety endpoint of BAV versus TAV. One of the key slides in this comparison. And what you can see is that the early event rates are very, very low. You can see that there, 96% freedom from mortality and structural valve deterioration. But that's the early. The 5-year data, though, which is the important one, compared to the TAV and BAV, is really, really incredible when you think about it. These are younger patients, 96% freedom from mortality, and also structural valve deterioration, 0 structural valve deterioration at 5 years, and 214 BAV patients with an average age of 59. And there's the structural valve deterioration. Actually, there was 0 structural valve deterioration in either of the cohorts at 5 years. But as was just presented, one of the TAV cases had a structural valve deterioration just after 5 years. And there's your mortality data. Now, this is interesting. Now we're looking at the BAV cohort that's super young, which is the less than 65 cohort, versus the BAV cohort that's a little bit older at 66 to 75. And you can see even in the younger patients that the mortality, there's only one death. This is a a freedom from death of 99.2% or less than a 1% mortality rate. And structural valve deterioration is 0 at 5 years in this very young BAV cohort. Now, this is the echo-derived mean gradients in the BAV cohort versus the TAV cohort. So focus on the orange. And you can see that really what's important here is that there's basically no change from 1 year all the way through 5 years in these BAV patients. And this is Echo Core Lab adjudicated. Now, paravalvular leak is incredibly low. And some people would say that there could be a little bit of a higher paravalvular leak rate in BAV patients, especially Sievers zeros. But in this particular study, the paravalvular leak rate was basically almost 0 in both groups, but even less in the BAV group at 5 years than the TAV group. So these paravalvular leak rates are basically 10 times less than you would get in a TAVI. And you can see that none of them are really moderate. They're all only mild, and there's only a few of them. So this is a shout out to the surgeons in the COMMENCE trial. They all did a very good job. Now, this is transvalvular gradients, which I think are really important. This is looking at BAV patients, the young group, less than 65, versus the little bit older group of BAV patients. Now, transvalvular regurgitation is really a marker for structural valve deterioration. It's actually a very early marker for structural valve deterioration. So it actually happens before you would actually get an explant. And so these are really important things to look at, transvalvular regurgitation. And you can see they're very low and less than 5%, and even only 2% in the BAV young group of less than 65. And that's the other issue, is that even in these young patients who you would think would have more structural valve deterioration maybe a little bit earlier in the young BAV group, there's still almost no transvalvular regurgitation at 5 years. And this is looking at the gradient changes over time, looking at tricuspid versus bicuspid, and focus on the right panel, because it's a model that's adjusted for valve size, adjusted for age, and body surface area. And you can see that the p-value is 0.8, and that there's really no difference in gradient changes over compared BAV patients compared to TAV patients. And it's also really a small increase. It's not even statistically significant. Now, this is not just from this trial here. This is an abstract that was at the ATS from Cedars-Sinai, looking at BAV cases, BAV disease, surgical AVR. And what you can see is that they had 402 isolated AVRs. They also had aortic root procedures as well. And the results were a 0.2% mortality rate for isolated BAV, a 0.7% stroke, and a 4.2% pacemaker rate. These results, like the results that we just saw in the COMMENCE BAV data are just spectacular. So this gets us back to the guidelines, and we look at this, and we see that the guidelines are the American guidelines are pretty solid over 65 for tissue. For 50 to 65, it's mechanical or bioprosthetic, both at a level of 2A. And you may think that that is where these new data might shift these guidelines at the next iteration. And in the less than 50-year-old group, the guidelines suggest either mechanical AVR or give a Ross procedure a 2B. And you wonder the next guidelines with this new data, whether there's going to be a shift in the less than 50-year-old group as well, although the data is still not quite out there for that group. So we're going to have to see, but this is the data. These are the kinds of data sets that will be informing the next set of guidelines. So this is beyond the consensus regarding tissue valves at earlier ages. Now, this is an interesting slide from the European guideline. This is a new concept in the guidelines for less than 50 years old. So a bioprosthesis should be considered in patients for whom there's a low likelihood and or a low operative risk for future redo valve surgery. So this has never really been in the guidelines before, looking at the concept of a low operative risk for future redo valve surgery. So we'll have to see how this gets expanded in the guidelines in the future. So it'll be interesting to see where the guidelines come in for younger patients vis-a-vis tissue AVR in the future. And the bottom line I say to everybody is it's all about judgment and understanding all the data behind it. So thank you very, very much. I will stop sharing there. And we'll bring it back to Dr. Borger to finish off the third lecture. Dr. Borger?
Thanks, Joe. I'm having trouble starting my video. I keep clicking the button here and it won't turn on. Anyway, okay, I guess we don't need my video. I'll just go ahead and share my screen and start with the presentation. You can see that, correct?
Yes, I can see that.
Okay. Thanks, Joe, for the great presentation and a great segue into my topic, which is looking at lifetime patient management and the European guidelines with a little more focus on the situation in Europe. These are my disclosures. At the beginning of the session, it was stated that I receive honoraria from Edwards. I don't. My hospital receives them in addition to these other companies listed here. So this is a great paper that I would suggest for everybody to read when they want to learn a bit more about lifetime management of aortic stenosis. It's written by Stefan Windecker, an interventional cardiologist from Bern, Volkmar Falk, cardiac surgeon from Berlin, amongst other people. And this is a fantastic summary of all of the different issues that we have to take into consideration when we're trying to decide with a patient if they would like a bioprosthetic valve, what the best option for that patient is, depending on their age, depending on their comorbidities, et cetera, et cetera. And of course, if Salver or TAVI should be implemented. I would say this is a great paper, but there is one problem that I have with this, and this is the younger age group where they suggest as a possibility a TAVI first strategy. And I'll get back to that, why I do not think that is a very good option. But I want to just state also that I'm not one of these chest thumping surgeons that says that everybody needs an aortic valve operation. I truly recognize the paradigm shift that TAVI has brought to our patients. And certainly we have one of the largest TAVI programs in the world here in Leipzig. And there's a reason behind that we do believe in this technology. However, we also need to know the limitations of this technology, not just for TAVI, but obviously for Salver as well, for any bioprosthetic valve prosthesis. The Achilles heel continues to be structural valve deterioration. And when we are considering what kind of valve to implant in a patient, we mostly look at life expectancy and the age at the implantation. And you can see the average life expectancy charted on this graph according to the patient's age and according to the patient's sex, which of course also plays a big role. One thing I also ask of my patients, in addition to this sort of gestalt assessment of how long I would expect them to live, is I always ask them how old their parents were when they passed on, or if they're still alive, because that also plays a role in approximately how long they're going to need to continue using their valve. So there's been many publications out there on the long-term durability of salver prosthesis. This publication everybody is familiar with, published already 8 years ago from the group from Tours. And what they demonstrate is for the perimount valve, that we have really superb outcomes, especially for the elderly patients. But something that I think that is kind of lost on a lot of people, that even in the young patients under 60 years of age, that the average time until the development of clinically relevant structural valve deterioration was approximately 18 years. Which is a lot longer than I think a lot of people think. And certainly when I ask medical students how long a bioprosthetic valve lasts, they usually say 10 years. And I always question them, where do you come up with this 10 years? It's actually not true. The valves last a lot longer. And of course, the newer generation valves, like those treated with the RESILIA tissue, we don't have the 25-year data on, but I just like to make the analogy. I don't know how many of you drive a 40-year-old car. I don't. I trust that the auto industry, at least the companies that have been doing this for decades and have been doing it extremely well, are making progress, and that the newer platforms, which are for the most part not major modifications of the previous platforms, should behave just as well, if not longer, in the long run. TAVI durability, of course, we have less data on. However, we should recognize that this is completely different structure of the valve compared to the previous bioprosthesis on one side, and therefore we have to be a little more careful when we start applying these valves into younger patients. On the other side, I can tell you in Leipzig, we've put in 10,000 or over 10,000 TAVI valves, and we're certainly not seeing these patients showing up routinely with structural valve deterioration. So, of course, we have to wait longer because the first couple of years of TAVI were in high-risk elderly patients that are all probably dead by now. But even as we've been moving along into younger patient populations, it's certainly not the case that we're routinely seeing these patients, okay? So there may be issues with durability, but there's no major issues with durability, definitely not. Another thing that we need to take into consideration is the importance of following up. This is a meta-analysis that was published last year in EJCTS, and looking at all SAVR versus TAVI randomized trials. Of course, most of the trials that were done at the beginning were with earlier generations of TAVI, and there have been advances made in the TAVI technology. But you can see here that after about 2 years of follow-up, the surgical team patients actually have benefit. And we don't know exactly why, what it is about the TAVI prosthesis. It's not failing, but certainly we do have more paravalvular leaks, like Joe alluded to. And that may have some implications for long-term results. And that's important as we move into younger and lower risk patients for TAVI. So this is the summary that these authors came up here with. Also a very good paper by Fabio Bavaria and his colleagues. So then you say, okay, well, if structural valve deterioration occurs, it's no problem. We can just do a TAVI valve and valve and everything will be great. Well, there are also some limitations to this so paradigm shift technology or approach. This is a paper that has already been published many years ago in JAMA. Everybody has seen this many times, but just to reiterate one more time, patients that receive a small SAVR and then a subsequent TAVI in that small SAVR have a very bad prognosis. You can see here a mortality rate approaching 30% only 1 year after procedure. So you say, well, what is a small valve? Well, small valve is all valves that were 21 millimeters or smaller. Then you may say, well, I don't put in 21 millimeter valves or 19 millimeter valves. And I would say that's not true. If you look at this paper from STS database, 140,000 patients, you see that 1/3 of patients received a 19 or a 21 millimeter valve. The smaller the valve is, the earlier it fails, and the less appropriate it is for a valve-in-valve procedure in the future. So those are some of the things that we need to be taking into consideration when we're talking about lifetime management. Of course, we have the Inspiris valve with RESILIA treated tissue and a expandable frame. that we think will facilitate a future valve-in-valve, enabling us to put a larger TAVI prosthesis inside of this expandable frame. There's been a couple of these procedures done, not a huge experience, but it seems to be a concept that works. And one other nice benefit is that you have the labeled size of the valve on the frame that you can see with fluoroscopy. So getting back to my first slide or second slide, when I said, TAVI first for young patients is probably not a good strategy. Why did I say that? Well, this is one of many papers that have been published. There were 2 published last week as well in JACC Cardiovascular Interventions. But this is a meta-analysis, and you see it's not a small one. It's over 1,500 patients that underwent SAVR after TAVI. These were high-risk patients with an STS score of 8.1%, but these are difficult operations. We're not doing them well as surgeons. Why? It's a bit speculative right now, but we do know a lot of them require concomitant surgery, especially aortic repair, that we do have a lot of adhesions that occur with the aortic wall, and sometimes there's damage to the aortic wall when explanting the valve, leading to more extensive repairs or even a Bentall procedure. So what were the results? The results are not good. Also in those 2 papers published last week, they're not good. We have a mortality rate that is over 16%, twice what the STS predicted risk is. Basically, for any other surgical procedure we do, the STS is either accurate or may even a bit overestimate their risk. Here, we see it definitely underestimates the risk of the procedure, even after excluding endocarditis. So something about this operation that we don't do well, and that should be taken into consideration when we're talking about lifetime management. The European guidelines, I'm not going to go into them in detail because Joe talked about most of the points already, but I just do want to point out is simultaneously published in the European Heart Journal and the EJCTS, so a cardiology and a cardiac surgery journal. This is a collaborative effort between a cardiology and a cardiac surgery society, and I know the newest version of these guidelines is also going to be a collaborative effort. 1/3 of the authors on the task force were surgeons, with many of the others being either interventional cardiologists or non-interventional cardiologists. And that's in contrast to the American guidelines published in 2020, where there was only 2 of 15 members were cardiac surgeons, and was obviously only coming from a cardiology society and only published in cardiology journals. Why is that important? Well, I would just like to point out one possible issue that may not have been come to fruition in the guidelines if there were more surgical input. For example, in asymptomatic patients, it was recommended that a TAVI or a SAVR are both possible, and you should follow the same recommendations when deciding either TAVI or SAVR. Well, I would argue with this recommendation because there's 2 trials and very powerful trials. This one you already saw from Joe. This is from Seoul, South Korea, and very clearly showed a survival benefit for patients that received SAVR compared to watchful waiting in severe asymptomatic aortic stenosis, so very severe, more than 4.5 meters per second. So here we have one randomized trial showing survival benefit with surgery. And here we have a second one, the AVATAR trial from Marko Banovic and colleagues from Serbia, showing also a significant reduction in the MACE rate for those patients that underwent early surgery versus conservative treatments of watchful waiting. These patients did not have very severe AS, they only had severe AS, so more than 4.0 meters per second, and they were also asymptomatic. And we also saw for mortality a signal that SAVR is also beneficial, but for MACE, a statistically significant difference. So we have 2 randomized trials showing surgery is better than nothing. So how many randomized trials do we have for TAVI for asymptomatic aortic stenosis? We have 0. And yet they're both basically placed at the same level of evidence within the American guidelines. So this is just one of the fine points that you may want to interpret a little more carefully when you're comparing the 2 sets of guidelines. Of course, there are several TAVI versus conservative therapy randomized trials coming out soon. The results will be known, but you may argue, well, now that surgery has been shown to be the gold standard, maybe we should be comparing TAVI versus SAVR for asymptomatic patients, but that's another topic. And the second last slide I would like to show, this one Joe alluded to before with the earlier version of the guidelines, but the most recent version, we also have some differences regarding SAVR versus TAVI and age cutoffs, mechanical valves obviously being recommended for the very young patients, but here you see for the European guidelines, they say 75 is the hard cutoff, and then you look at the risk profile of the patients, whereas the Americans have a little more flexible interpretation going all the way down to 65, and taking more into account the anatomic challenges that would be argue against a TAVI. So those are two very different interpretations of the same data. Finally, I would just like to say in the European guidelines, the supplementary data is also interesting to look at, because there were obviously differences of opinions when the guidelines were being written within the task force members. So the ESC and the EACTS each had their own methodologists to look at the randomized trials that were published in the past. And this is the table that you find in the supplementary data summarizing the comparisons. And you'll see, first of all, that the overall assessment of the trials show that there's room for improvement, let's put it that way. So green means there was low risk of bias, yellow means there's some concerns of bias, and red means high risk of bias. And you can see, at least for the earlier SAVR versus TAVI valves, there was consensus that those trials had a high risk of bias from both the surgery and the cardiology methodologists. And these high risks of bias are things that we need to be taking into consideration when we perform future randomized trials for it. So in summary, TAVI is being applied in an ever increasing number of aortic stenosis patients, especially low risk. And I think that this is generally a good thing, but we need to also be aware of the shortcomings. And the Achilles heel for all bioprostheses, SAVR and TAVI, remains structural valve deterioration, but is probably going to be lower with the new generation valves, as you've heard today. Durability of TAVI still needs to be demonstrated, but what we're seeing so far is no reason to be overly concerned, but we are a bit concerned about the SAVR post-TAVI operation. And then finally, the guideline development is an imperfect process, and we need more properly designed randomized trials to help us guide us with our daily management of patients with aortic stenosis. Thank you very much for your attention.
Well, great. Thank you very much, Michael. And let's go to a chat here if they can put us all on the screen. So my question, so let's start talking a little bit about some of these things, because this is really an interesting topic. So I have a number of things. Let's talk about the BAV stuff real quick first. When we had the BAV presentation, the BAV, even in that very low risk group, was 0 at 5 years, and that in Tom's presentation at 7 years, both of the structural valve deteriorations were TAV patients. Any thoughts about the Inspiris valve or RESILIA tissue in these younger patients in the mid to late 50s on average? Is this what you do, Tom? Was this what you do, Michael, for BAV patients?
Well, go ahead. Yeah, I think for younger patients it goes down to the shared decision making, and I'm very open to the tissue valve in a younger patient if that's your question. I don't have a problem doing that. Mm-hmm.
Yeah, and I completely agree with Tom. I have no problems with it as long as the patients are aware of the possible implications. And the BAV patients seem to be a particularly appropriate group, because you can get a larger valve in. We know that the annuli tend to be bigger. They have more severe calcification, like Joe said, which has implications for TAVI, but for SAVR, very little implications. And if you look through the data trying to compare tricuspid versus bicuspid aortic valves for SAVR, there's almost nothing out there, because nobody ever dawned on the idea to compare the two, because the outcomes are the same for us as surgeons. It has virtually no implications for us. but it has implications for TAVI. So young person that wants a bioprosthetic valve, I have no problems. And especially with what I think the RESILIA platform seems to be a winner.
Yeah, we can go into that a little bit deeper. There are some early signs regarding the intravalvular or valvular ASAI in these, in these RESILIA patients, even out to 7 years now. You would expect to see a little bit more of this if that's the first sign of structural valve deterioration, and it's pretty minimal. A couple of questions from the audience, if you don't mind, guys. So one question was, in your practices, when you do a redo SAVR after a tissue valve failure, do you put a mechanical valve in or not? And how do you think about it? Michael?
I like Michael. I'd ask the patients how old their parents, lived. And then I think, one of the key takeaways is if you are going to do a redo tissue valve, that make sure you put a big enough one in and you do a root enlargement. I think that's really what I've been learning over the last couple of years is it's the lifetime management of these patients. And one of the key takeaways I've taken over the last few years is you really got to, if you are going to go tissue valve, just make sure you have a big enough valve for a future transcatheter valve.
Yeah, I would agree with that. Yeah, Michael, what are your thoughts, real quick?
I completely agree with what Tom said. And some patients just do not want a mechanical valve. If it's their fourth time redo, I suggest a mechanical valve, obviously. But even then, sometimes the patients say, "No, I don't want it."
Yep. So there's a couple questions regarding TAVI explant. Any ideas about how you would approach a TAVI explant? Do we need to get better at them? Should you, always plan on possibly doing a root procedure in TAVI explants? What are your thoughts about getting better at TAVI explants? Michael, start off with you.
Yeah, we've got a big experience with it because of the number of TAVIs that we've done. And we've got a paper that's being circulated right now where the worst patients are those where the TAVI's been in for longer. More than 18 months makes the reoperation more difficult and more risky. The early ones, you can usually get them out without too big of a problem. After that, especially the self-expanding valves, because the self-expanding valves, you have also the problem of you have to cross clamp way high. You have to make your aortotomy way high. You're looking, you have to go way down to get the whole thing out, hopefully without ripping the root to pieces. And then once you've got it out, you're still working through a tunnel down to get to the aortic annulus. So all of those things seem to be playing a role, and we just need to get better at it, and we need to keep talking about it, how to improve the outcomes.
Yeah, I would totally agree with this. I think that these operations are certainly not as easy as we thought. I think that the concept of doing TAVI first is maybe fraught with danger in many respects, especially in younger patients, because of or partially anyway, because of this concept. This data is coming out more and more. So Tom, what do you think about Michael's presentation, which I thought was pretty interesting, about the fact that STS score, he's right, usually does actually overestimate just a touch, but in the TAVI explants, it underestimates by 100%, 16% versus 8%. What are your thoughts about that?
Well, I think as you've shown, and even at the ATS in Los Angeles, the Michigan team presented and they had a similar mortality. It was 15% with TAVR explant. Now, that you have to remember, they're explanting the earlier patients, the partner one, or the earlier higher risk patients, and then when they come back for their explant, they're also doing a mitral valve, or they're doing a CABG, and they're doing more surgery. That makes it more complicated. But there's no question, those of you that have done these surgeries are more complicated, and for that reason, in terms of his guidelines, and I've not been a fan of the TAVR first. People kind of suggest that. I think the key is if you are going to go tissue, go SAVR, and make sure you put a big enough root, planning for durability for a lifetime.
The other thing that from Shin Fukuhara's group, who's published a lot of this from Michigan, that was his meta-analysis, or his group's meta-analysis, even independent of endocarditis, we still see a very high mortality. And we saw that also with our multi-center registry. Matteo Morin-Coates is just presenting at the Euro PCR with Gilbert Tang's group that he put together. And again, there's just something about this patient population that they do not do well, even those ones that were treated as low risk with TAVI. And the endocarditis is interesting because they tend not to, I know this well from looking at the literature very closely, they tend not to have the big vegetations on the valve where you say, oh, this is definitely endocarditis. They tend to get the infection around the stent and into the periannular space, which of course makes the operation more complex. And so they present later and before finally somebody says, oh, this is TAVI endocarditis. And then you've got a pretty destructive process down there at the annulus by the time they get their surgery.
Absolutely. It is something that needs to be not only understood better, and the surgeons need to understand it better, but actually the cardiologists need to understand it a little bit better too. So there's a question, a number of questions revolving a renal failure in a couple different domains. Let's go through them. So one question is, if you have a 55-year-old patient with aortic stenosis who's on dialysis and who does not have a contraindication to Coumadin, what kind of valve would you put in? Michael?
I would talk to the patient very carefully about the risk of structural valve deterioration, which is no doubt increased massively for dialysis, and the risk of Coumadin, which is also a big problem for the nephrologists and for the dialysis people. And I've looked at this data also very closely, Joe. There's just no real good answer, and I need the patient to guide me.
Yeah, it's very difficult. I'm just not sure whether the old data is going to hold up. It's kind of a moving target. So, Tom, when you looked at the 7-year data, and Michael already spoke about the fact that smaller valves have higher rates of structural valve deterioration. And it is very, very interesting to note that when you looked at that STS paper of 150,000 patients and you compare it to the COMMENCE trial, the COMMENCE trial patients had much, much bigger valves than that US snapshot back in 2015. So that means we're getting better, which is great. But their other structural valve deterioration in the 7-year data was a CRF patient, a chronic renal insufficiency patient. You want to discuss that real quick?
Well, that patient also had peripheral vascular disease. I think that there's no question that those patients, I think, are going to lead to whatever the milieu is in their body. They're going to, it's going to promote tissue degeneration at a faster rate. I think from a broader perspective, a lot of dialysis patients, the mortality in a couple of years is 50% in dialysis population. And so you're kind of dealing already with patients that may not live. You have to look at all their comorbidities, how much vascular disease they have they had, had amputations, or what the whole picture of the patient looks like in general. And we actually don't have a problem doing TAVR in those patients if we can get a big enough TAVR in, because I just think that they don't do well in general, a lot of those sick dialysis patients.
Yeah. So, most trials, guys, when you look at them pretty closely, will have a 1 to 2, this is a regular standard SAVR trials, we'll have a 1 to 2 to 3% structural valve deterioration rate at 5 years. But it doesn't really start to dip lower until about 8 years or so. We know that we have, if you count the European feasibility trial, we have 833 patients at 5 years with RESILIA with 0 structural valve deteriorations, and in the 7-year data with only 2 out of 233. So what are your thoughts? You think this is going to end up, or do we need more data? Michael, what are your thoughts?
Yeah, we need more long-term data, but important to stress is that this is a young patient population. So as you showed in the COMMENCE 7-year data trial, Tom, those patients were 69 years of age. This is a younger patient population for a bioprosthetic FDA IDE trial that we've seen in decades. And therefore, this is a robust population for SVD, and nonetheless, we're still seeing very little of it. Joe, your bicuspid aortic valve patient group was only 59 years old. They're very young. They should be calcifying these valves very quickly, and we're just not seeing it. So I'm quite optimistic about this valve and this tissue platform.
So Michael, when you look at the BAV data, which is really the first large-scale FDA IDE data on 233 BAV patients, 215, and the data is incredibly good. We'll have to follow it out maybe a little longer. Should this be a baseline study for BAV results as we move forward in both SAVR and TAVR?
Yes, and we need to nonetheless do a randomized trial. I think the time is beyond us where we just sort of rely on single patient series without a control arm and our gut feeling. We need more and more randomized evidence, and the time is ripe for a randomized BAV SAVR versus TAVI trial.
Well, I think I have only time for one more question as time is coming to an end. So let's make it a big question. The last slide you showed, Michael, was about some bias, and this is actually in the chat box as well, regarding some of this RCTs. So I have a question for you guys, and please answer fairly quickly. Do you think that obviously we need to work better on the RCTs, but what about, in your opinion, what's a better set of data, an RCT or a well done, statistically analyzed a big data set like the TVT database or something of that nature with 100, 200, 300,000 patients? Michael, start with that.
Yeah, well, you know what I'm going to say. It's a randomized trial. It's the only way to efficiently remove bias. You don't remove all bias like I showed in that paper. That's from a working group of surgeons and cardiologists that published that in JAMA, a very high-ranking journal, showing that there's systematic biases regarding concomitant procedures, loss to follow-up, and other things that can happen during a trial that were all against SAVR. Okay, why exactly that happened, don't know, but those are demonstratable with that paper, and I would suggest people read that. Nonetheless, randomized trials are the best way to eliminate bias, and all of our single series retrospective data is heavily influenced by bias.
Right. Tom, real quick, big continued RCTs or good big data analysis?
I think no question RCTs, you just got to have enough patients and it has to be designed right.
Okay, so you're the same as Tom. I'm going to take the opposite tack. I've changed a little bit over the past 5 years. I think really outstanding analysis of huge data sets may actually give us more information than an RCT. So with that, we have some great questions in the chat box and a Q&A. I just don't have any more time. I have to take the prerogative of the moderator to close this out. I want to thank Dr. Beaver and Dr. Borger for their presentations and their participation, as well as Edwards and CTSNet for producing this content. So for all of the listeners and participants, have a great day. And thank you.
Joe, don't forget, they should fill out the survey too. There was a text that was just sent from John to everybody. They should fill out the survey.
Okay, fill out the survey. Thank you very much. Bye-bye.
Thank you. Thanks,
Bye.
Joe. Thanks, Tom.
Thank you everyone for attending this Edwards Life Sciences and CTSNet webinar. You can view the recording on Friday on ctsnet.org and CTSNet's YouTube channel, along with hundreds of additional cardiothoracic surgery videos. Also, be sure to check out the Edwards Learning Network, an online library of educational assets available at learning.edwards.com. Last but not least, we have placed a link to a brief survey in the chat window and would appreciate your feedback on this program. Have a wonderful rest of your day.